All right, morning everyone. The topic this morning is choose health and happiness. To start the morning, turn to the person next to you and just say, I'm very happy. Absolutely. So it's important that we affirm happiness in the room this morning. All right, so in terms of the objectives of the presentation, and I'm told I must ensure that the objectives are met, we'll be looking at suicidal behavior, prevalence of suicide in Jamaica, some of the factors, the predisposing factors, or factors that predispose to suicide or are associated with suicide, and the role of the pharmacist and other healthcare professionals in dealing with this. And I have put this one in because I think, yes, we can talk about suicide and it's good and also, but I think as a good psychiatrist, I must share with you some tips in terms of securing your happiness so that we don't get suicidal in the room. Now, why is this topic of interest to the pharmacist? One, of course, you're an important member of the health team. Overdose of drugs, poisoning is a common method, and you have to dispense a lot of these medication. And even at the point of service delivery, you can monitor and get a sense of what patients may actually be doing. But also, you're an important gatekeeper in the healthcare system, an important entry point, trusted. The clients, the patients will often come to you, discuss issues and so on. So it's important that we all become involved and are aware of these issues. Now, I have a few questions for us. And the first question is, who is at higher risk for suicide, male or female? Those who say male, let me say All right. What's that? They don't what? They don't talk as much. So talking is an issue, right? And they don't communicate feelings. But you're correct. The data shows that the majority of persons who attempt suicide are females, right? But males, more males than females actually commit suicide. True or false? And this is another question for us. The majority of people who commit suicide have a mental disorder. False? Let's see the answer there. True. Didn't get this one right. 90% of suicidal patients have a diagnosable mental disorder. Who is at higher risk? Older person or younger person? You say, let me see those who say older. And younger? All right, and Professor Sher will be talking to us this morning on aging and so on. But let me see what we have here. Well, I won't give you the answer now. When I present the data, you'll see it and we'll come back to that. So we have to keep you interested. But suicide is a complex, multi-causal public health issue. It's a leading, not the leading, but a leading cause of death globally. And I must hasten to say that the suicide rate in Jamaica is low, right? One of the lowest in the world. Yes? I will come back to that. Anybody has a sense of what our suicide rate in Jamaica is in terms of per 100,000? 500? No, too high. It's so you say it's about what? 3. It's actually about 2. Yes, 2 per 100,000. But let's quickly look at suicidal behaviors. We talk about suicidal ideation, which are the thoughts, right, of engaging in a self-injurious behavior intending to end one's life. But the thought, and the suicide plan is a formulation of a self-injurious behavior with the intention to end one's life, right? So it's a formulation, that's the plan. And then the suicidal attempt is engagement in a self-injurious behavior with the intention of ending one's life. And of course, suicide. And we don't like to use the word successful suicide and things like that, because there's nothing successful about that. But suicide is death as a result of self-injurious behavior with the intention of ending one's life. And I've included deliberate self-harm, which is really a term that we sometimes use, because not every suicide attempt is really with the intention of, well, if it's suicidal attempt, it's intention to harm yourself. But many instances, what we're really seeing is deliberate, it's really self-harm. And people tell you the intention was not to what? Hurt myself. Maybe it's to get attention or to cry for help. And so it's important that we make that distinction. Now, some of the predisposing factors for suicide: age. And in fact, worldwide, there are two peaks: young adulthood and elderly. Yes, so we hopefully answer the questions, and we'll see how the data here in Jamaica compares with that. We mentioned gender, males, more males will complete suicide, low socioeconomic status, of course, mental health problems, and we discussed that early. Family history of suicide put persons at risk. Prior suicide attempt is an important one, and probably one of the most significant predictor of suicide, a prior attempt. So if somebody has attempted before or several times before, it must be taken seriously. Alcohol and substance use, persons with chronic illnesses, especially chronic debilitating terminal disorders where they become depressed and probably hopeless, right, are at great risk for suicide. And of course, access to lethal methods. And that's why males, the suicide rate among males is actually higher, because they tend to use more lethal means. They'll shoot or use poisons and so on, right? Okay, now, I hope I don't overwhelm you with too much data, so I'm going to go through some of this quickly. So we looked at ideation, because that's where it begins, right? And in Jamaica, some years ago, we did a school-based study, and what it showed was that the prevalence rate of suicidal ideation was 10%. So 10% of children in Jamaica between 10 and 15 years old admitted that they were having suicidal ideation. Yes, and that's cause for concern. Yes, and the problem with young people and suicide is that they are, even if it's not their intention to actually commit suicide, because they're so impulsive, right, and have such poor regulation in terms of their mood, right, it puts them at greater risk of committing suicide. And then when we look at the suicidal ideation in youth in Jamaica, what we saw were some of the risk factors. Females were at greater risk, or they had reporting more suicidal ideation. The young people who said they were depressed reported more suicidal ideation. And young people who were being teased or bullied, yes? And you know, over the past maybe decade or two, the word bullying has become very sexy, very, very topical, right? When we used to go to school, we used to say children were teasing us, and they called us we didn't even consider it to be bully. But nowadays, right, we're now labeling a lot of the behaviors as bully, and that's correct. It's correct, right? And they can be bullied anywhere, at school, in cyberspace. They talk about cyberbullying and so on. And for young people, it's a major risk factor. They're being bullied, they feel vulnerable, nobody to support them. They sometimes feel like, look, maybe I should get out of this world. Some of the protective factors are on the right. We found that young persons who like themselves, who have positive self-esteem, those living in the rural areas, and those who had what we describe as protective factors in the home, like parents who were with whom they could speak, parents who were there to supervise the things that they were doing. We found that those things actually protected them from suicidal ideation. And then this is some additional data. We looked at persons who presented with deliberate self-harm into the emergency rooms. room at UHWI in 2015. And what we found is that the majority were female, mean age 25. So it's young female, single, so young single female. Majority live with someone, majority unemployed. Main method of harm is overdose of medication. And I'm sure as pharmacists you can relate to this, right? The overdose is a problem with the young females. And what we found was that there was a significant association between reason for self-harm and psychiatric illness. In fact, maybe I should have included a slide here, but 80% of females, large percent, who repeatedly attempt suicide, and you probably know some of them, right? Invariably report a history of childhood sexual abuse. Yes? And I see some of us shaking our heads, right? And many of them have what we call borderline personality disorder. Yeah? But the childhood, in fact, sexual abuse in childhood put persons at risk, tremendous risk, great risk for long-term health problems, but also mental health problems, including depression. Now, this is another study that was done at the UHWI emergency room and looked at suicide attempt by self-poisoning. Again, more females than males. And they reported interpersonal conflict as being the most common reason for the self-poisoning. And of course, again, as pharmacists, you can relate to this. Analgesics was the most common group of drug use, and of the analgesic, acetaminophen was the most common drug. Everybody, almost everybody has a stock of acetaminophen in their medicine cabinet at home. Now, suicidal behavior. We looked at suicidal behavior among adolescents, and we also looked at their alcohol use. And I think the most important point here is that the suicide risk prevalence was about 20%. What we had done is that we used a scale to actually measure their suicide risk. And we found that 20% of our adolescents were at risk for suicide, either because of significant suicidal ideation, previous attempt, or recurrent thoughts of suicide. Now, I'm going to take you, and bear with me, with a little bit more data. Looking at suicide in Jamaica between 2002 2010, and this is probably the only series of data we have on suicide, which is really good data. And of course, it showed majority of suicide cases were male. Hanging in Jamaica was the main method used to commit suicide. And what we found was that there's what we call a bimodal distribution. There are two age groups, the 25 to 34 age group, young adult, and over 75 were the two groups in which we saw the peaks in terms of suicide. And I'd pose a question to you. What are the reasons you think you're over 75 would be at risk for suicide? What are some of the things that come to mind? What's that? Loneliness? All right, and I'm not going to go, I'm sure Prof. Shira will discuss some of these with you, right? So I won't venture into her presentation, right? But over 75, Prof. Shira, you have to address what's happening in this age group. This is the suicide rate in Jamaica. Noisy chart, but if you look to the right, the important point to remember is that the suicide rate is what? 2.1. And you'll realize that the graph is going up and down, right? Some year it dips, some year it peaks. And then when it peaks in a particular year, you see the headline on the paper, suicide on the increase in Jamaica. But over time, it's up and down, but over time it's about, it's stable, and it's about, the easiest way to remember it is just to say 2 per 100,000, right? Rather than the 2.1, right? And this is an interesting slide. Came in a little late this morning because I wanted to get this slide in. When I was thinking about it, I said, we should compare. I mean, we should be, how do we compare with other countries? And this is WHO data 2016. And they show that Guyana is at the top, in terms of suicide rates in the world, at 30. Followed by Suriname, which is 23.2. And this compares with USA, where it's about 13.7. Trinidad is high, 12.9. and the UK is 7.6, Jamaica is 2, and Barbados is 0.4. And of course, one of the questions you're going to ask is, what are the reasons for it being so high in what? In Guyana and possibly Suriname. Any suggestion? It's not poverty, because when you look at Trinidad, for example, Trinidad is higher than us. It's because of the population distribution. The suicide rate is actually higher among persons of East Indian background. Yes, and you know, even Suriname also, Guyana, Suriname, Trinidad, they all have fairly large East Indian, persons of East Indian extract. And it has to do with, a lot of it is around young people being forced to marry persons they don't want to marry, and then they end their lives poisoned. So parents, the message you learn, don't force the children to marry who they don't want to marry. Okay? But that's the figure, and you realize when you look at the listing, Jamaica is way down, you know, and you say thank God for that, because, you know, we often say when it comes to all the bad statistics, we're rating there, right? And just quickly by parish, as you would probably expect, highest rate would be in Kingston, St. Andrew. By gender, we've touched that. The methods of suicide, that's a poor graph, but the most common is hanging. Poisoning and shooting, probably about the same. And by occupation, this is interesting. The highest group was a kind of professional group, business people, right? And the press is not here. But let me ask you a question. Of the professional group, which you think is the group with the highest reported suicide rate? What's that? What you say? You say...
Police and soldiers.
All right, she said police, right? And she's correct. Police and businessmen, right? They have, and of course, the police and businessmen. And I suppose it's because they have access to what? Guns, yes. Lethal weapon. We would all fall in number one, though, you know. So we're in a risky group. What is, look, the pensioners struck me. Well, students were about 10%, yes? And pensioners, 9%. That's actually interesting, right? But not surprised in terms of students. We told you that young people are very impulsive. But of course, pensioners, little pension just can't stretch. I see your distress on your face, right? Can't stretch, and it created a lot of stress, eh? And the question we ask is, why is the suicide rate in Jamaica low, comparatively low? And you know, when every time we go out there and we study and we ask persons, the factor they highlight is religious. People will tell you, even when I'm interviewing my clients, they'll say, Doc, even when their suicide risk is high, they say, I will never commit suicide because I want to go to heaven. Because there's a strongly held belief that if you commit suicide, you won't make it to heaven. And of course, there are the cultural issues. But some people also argue that in countries where you have a high murder rate, there's a what? Low suicide rate. And it's because of what happens is that we turn our aggression outward. And in some countries, they turn the aggression inward, right? All right, I think suicide among adolescents in Jamaica, hanging with clothing items was the most common method for suicide. I think we can skip this one. And I've now turned to depressive symptoms, because we know depression is a major risk factor for suicidal behavior worldwide. Although what is very interesting for us in Jamaica, some years ago we actually interviewed families, every family of persons who committed suicide. And what they told us, you know, it was not, what we got out of that data, it wasn't so much depression, but it was more psychosis. based on our data. But because we know depression is a major factor, it's important for us to just touch a little on depression. And when we look at our adolescents, 5% of them, relatively low but still significant, report depressive symptoms. 95% didn't report depressive symptoms. And what we saw, some of the protective factors with the depressive symptoms were protective factors within the home. And again, home. When the home environment is stable, when it's nurturing, when it's working, it's protective. But when home is dysfunctional, it increases the risk for depression, suicide, and all of those negative consequences. And risk factors are certainly negative community attributes, violence within the community. And we also found children with learning disabilities and problems reported greater depressive symptoms. Yes? But in terms of the role of the pharmacist, you should be able to identify persons at risk. And I know you do this, you're a good job at that in monitoring medication use. You can see sometimes when the benzodiazepine use is increasing or the antidepressant use is increasing, and these are usually signs that we probably should intervene. Fortunately for us, because we're not using the tricyclic antidepressants as much as we used to in the past. We're not having a lot of problems, suicidal related problems, because of course, the TCAs have what? A narrow therapeutic index. Unfortunately, the newer drugs, SSRIs, SNRIs, and so on, are safer. And people, you can take large quantities of these drugs and don't run into problem. But of course, as pharmacists, it's important that you monitor medication use. It's important that you collaborate with other members of the health team. And when you suspect any suicidal behavior, it's important that you refer. And as you interact with persons, be encouraging and empathetic. And so now, it's therefore important that you are aware of the suicide warning signs. And this one I took from the net. You monitor what people are saying to you, what they talk, the behaviors they probably may display, and the mood. Depression being a common one, right? Suicide and suicide prevention, learn to recognize the signs in older persons. 5 suicide warning signs in older persons. Isolation and loneliness. In fact, that is one of the things that contribute. That's a major risk factor. 2, stockpiling of medication. Doesn't mean that every time people stockpile medication, they're planning suicide, right? But failure to follow medical orders, reading material about death and suicide, and they report disruption in sleep patterns. But a lot of old persons will report these, right? But it doesn't mean that they're engaging in suicidal behavior or planning to commit suicide. All right. And some of the verbal signs of suicide. People would say, you'd be better off without me. Life is pointless. I wish I were dead. I can't take it anymore. I wish I was never born. I'm so tired of living. You won't have to deal with me much longer. When you begin to hear those comments from persons, certainly worrying, it tells you that they're probably they're depressed, they're probably hopeless at a point of desperation. And so, as a pharmacist, your step one, somebody comes to you and they're sharing these thoughts with you or they're expressing concerns, find a private place. And then increasingly, I say the pharmacists are equipped with consultation corners where people can come and share private, issues with you. Always find time, allocate some time, yes? And 3, listen. Sometimes the most important thing to do is to listen. And so what you can do, you're confronted with a person, stay with them, gently talk to the person, don't be judgmental. And every time I address the group, I tell people we must not use why questions. Why questions are bad questions, right? Person not taking their medication and they come up to the counter, why have you not taken your medication? You know it's not good for you. And the moment we begin to do that, people begin to feel humiliated. They feel put down. Why questions are horrible questions. And the customers will never come back to you. Right? So don't use the why questions. They're judgmental. Better question to use is, I notice you're not taking your medication. What are your reasons for not doing so? And a lot of times they'll tell you they can't afford it or the what? Side effects, yeah? In fact, side effects are probably the most common. But what question? What never ask why questions, bad questions, horrible questions. And when you go home this evening, if you want to create happiness in your home, get rid of the why questions. Why wasn't the rice and peas cooked, right? Why did you not do the chicken for me? Why did you not clean the carpet? And the more problem that, what's that? Worries in the camp wants to use those why questions. Right? So the tip, if you want to generate happiness, get rid of and in fact, even in relationships, you realize it's the why questions that create a lot of problems. When relationships are going awry, it's because people are using a lot of the why questions. And you're putting down each other, humiliating each other, making each other feel small. And you're not my father and my mother, and why are you talking to me like that? Avoid the why questions. What are your what? Reasons. In fact, the common one, and I share it with everybody, when young people come to me, and the parents grab them into the office, yes? And they don't, kicking and screaming, they don't want to say the psychiatrist. Who wants to say a psychiatrist, right? But remember, we say normal people with normal problem. So when they come in, parents will say, they're using ganja, talk to them. And they expect me now to jump on the young person and start beat up on them. Why are you using ganja? You know it's not good. And I revert to my what question. And I usually say, you know something? Many young people usually use drugs. And they usually have good reasons for doing that. What are your reasons for doing so? And the moment they do that, I'm not telling them it's right, But when I say, what are your reasons for doing so? Then they feel comfortable and they open up. So if you want to get things out of people now, don't ask why questions. In fact, people who like gossiping will tell you, they don't use why. They'll ask you, what are? You get more. I'm not giving you any more tips, Right? So gentle talk to person, contact health professional, refer. Sometimes you may have to inform family and then list support with the permission of the client if you think the person is at risk, right? What to ask? I'll go through this quickly. Do you feel sad? Have you ever felt that life was not worth it? Did you ever wish you could go to sleep and not wake up? Have things ever reached a point that you've thought of harming yourself? Good questions, right? And I've highlighted this, the PHQ screening instrument. Very useful tool. And many years ago, lots of the pharmacists would have them, because there's a particular pharmaceutical company that had the right to it, and they would, the company, right? But, and they would distribute it widely. And it's a self-administered questionnaire. People would fill it out, they get a score, and they can get a sense of how depressed they are. And we should bring it back, the PHQ questionnaire. It's an excellent screening tool for depression, and you should have it in the pharmacy if it's allowed, right? And so as I come to a close, we've talked about suicide and depression and all of those things, but my parting shot is that I must remind you, because charity begins at home, we can't get up every day taking care of people, are we not what? Taking care of ourselves, yes? And so you have to love yourself. And so this morning I want everybody give yourself the butterfly hug. And you're going to do it like this. Follow me. And tell yourself, I'm a wonderful person. I love myself. I take care of myself. And I will continue to pamper myself. All the time, every time. Yes? In fact, when I go to the coffee shop some morning, when I see the young lady, I said to her, how are you this morning? And she said, not too bad. And I said, stop that. Just say, beyond awesome. Right? So I give you one to use as of today. Anytime you say anybody, you're going to say what? Beyond, everybody, beyond awesome. And we must have an attitude of gratitude. Just love to, Yeah. Just we have to learn to be appreciative. So let's give the people who have organized today's conference an act of gratitude. Let's give them, yes, excellent. And as I come to close, find your passion. I find a lot of people come to me and they walk into my office and say, Doc, I just want to be happy. And I say, what is your passion? Make sure you have a passion, right? Something you love and you pursue that passion. It could be gardening. It could be, what's your passion? You don't have one? Find your passion. I'm sure you have a passion. What's your passion? You're the Lord and His ministry. So you're serving the Lord and doing His work. What's your passion? You haven't found it yet. Sometimes it takes a little while for us to find your passion, but we must find our passion. And I often say to people, find your center and make sure your center lies within you, right? You can't leave other people to make you happy, right? Can't be another boyfriend and husband and wife and girl, because when things aren't working, you become what? Unhappy. You have to find your own happiness within yourself, yes? And I'm not preaching a sermon. And take care of yourself. Please, Christmas coming, those of you who love Christmas, take care of yourself. Not saying that you must go up there, go out now and go jack up the credit card, but take care of yourself, right? And I always end my presentation with this. Some of you just tired of it, right? So when Christmas comes, you put that sheet on the bed, right? Right? Christmas night, you go and you just grab it off and you put on a tear up one, right? And you're going to bed to have a good night rest and your foot getting caught up in, yeah? The things that you work hard for, use them and enjoy yourself. Yes? So, and I won't be long because I know Prof. Shearer has to come on. But, all them, you go to bed at night time and you have your nice negligee and lingerie put aside. Yes? And you jump into the duster, button pop off, curry stain. Yes? Arm tear out. Yes? I know you don't do that, but we have to remind ourselves. We have to what? Take care of ourselves. And then while you're in the bed, rock and rolling, you're asking, where is he? Where is he? Where is he? And you don't know that somebody down the road in Victoria's Secret. Take care of yourself. Have a wonderful day.
Thank you, Prof. Abel. I tell you, when you come to the Cari-Med functions, you get a sermon, you learn how to handle yourself, your psychology, your psychiatrist, give you a lot of information this morning for free. Right? Right, Prof? Remember, don't use the Y and change the sheet. Perfect.
All right, thank you, Greg. All right, ladies and gentlemen, what a wonderful presentation that was, yes? Invigorating, exciting, absolutely mind-boggling. Why, for the first time, we actually enjoy the murder rate because without the suicide rate gone down. It's a bad thing, but it's true. Jamaica don't have that problem. All right, so at this point, I'd just like to invite Dr. Abel to come forward. Just want to tell you thanks, Doc, for that presentation. Always a pleasure listening to you. No more wise. We're going to do the gossip style. How it go? Thank you.